Adrenal excess disorder. Overview of adrenal gland. Adrenal cortex, outer shell. Mineralocorticoids, aldosterone. Glucocorticoids, cortisol. Secondary sex hormones, androgens and estrogens. Adrenal medulla, inner core. Works as part of the sympathetic nervous system. Produces epinephrine and norepinephrine. Cushing's disease and Cushing's syndrome. Cushing's disease, endogenous. Increased secretion of cortisol caused by increased amounts of ACTH secreted by pituitary gland. Cushing's syndrome, exogenous. Resulting from chronic and excessive production of cortisol by adrenal cortex or administration of large doses. Risk factors. Endogenous, Cushing's disease. Adrenal hyperplasia. Adrenocortical carcinoma. Carcinoma of the lungs, GI tract, or pancreas, pituitary carcinoma. Exogenous, Cushing's syndrome. Organ transplant. Chemotherapy. Autoimmune diseases. Asthma. Allergies. Chronic inflammation diseases. Signs and symptoms: moon face, buffalo hump, truncated obesity, weakness. Fatigue. Back and joint pain. Irritability or depression. Thin, fragile skin. Bruising and petechiae. Hypertension. Tachycardia. Weight gain. Dependent edema. Diagnostics, collaborative care, H&P exam. Mental status exam. Plasma cortisol levels. Plasma ACTH level. CBC, WBC. Blood chemistries for sodium, potassium, glucose. Dexamethasone suppression test. 24-hour urine for free cortisol. CT scan, MRI. Collaborative care. Decrease sodium intake, increase intake of potassium, protein, calcium. Monitor intake output, daily weight. Assess signs of hypovolemia. Skin care, protect against skin breakdown and infection. Medications, aminoglutamide, cytodran, ketoconazole, nizoral. Chemotherapy. Hypophysectomy, removal of pituitary gland. Adrenalectomy, removal of the adrenal gland. Addison's disease signs and symptoms. Hyperpigmentation. Weakness and fatigue. Nausea and vomiting. Dizziness with orthostatic hypotension. Severe hypotension. Dehydration. Hyperkalemia. Hypoglycemia. Hypercalcemia. ATI nursing education. Adrenocortical insufficiency caused by damage of the adrenal cortex. Decreased aldosterone and cortisol. Adrenal crisis, medical emergency, acute adrenal insufficiency, caused by sepsis, trauma, stress, adrenal hemorrhage, steroid withdrawal. Risk factors. Primary, autoimmune dysfunction, TB, histoplasmosis, adrenalectomy, cancer. Secondary, steroid withdrawal, hypophysectomy, pituitary neoplasm. Diagnostics, collaborative care, medications, H&P exam. Plasma cortisol level. Urine cortisol and aldosterone levels. Serum electrolytes. ACTH stimulate test. CT scan, MRI. ECG, X-ray, CT. http://www.youtube.com/watch. VE = QFC2T9 Collaborative care. Monitor fluid deficits. Administer prescribed hydrocortisone, continuous infusion of boluses. Treat hyperkalemia. Treat hypoglycemia. Medications: hydrocortisone, Cort-F, prednisone, cortisone, fluorocortisone, Florinef. Hyperaldosteronism risk factors: characterized by excessive aldosterone secretion. Hallmark disease: hypertension with hyperkalemic alkalosis. Primary hyperaldosteronism, PA, caused by small solitary adrenocortical adenoma. Secondary hyperaldosteronism occurs in response to a non-adrenal cause and elevated aldosterone levels such as renal artery. Risk factors: age 30-50 years. Renal artery stenosis, renin-secreting tumors, chronic kidney disease. Signs and symptoms: diagnostic, treatment, CT, MRI. Hyponatremia, hypertension, headache, muscle weakness, fatigue, cardiac dysrhythmias, glucose intolerance, metabolic alkalosis, tetany. Diagnostic: CT, MRI. 18-hydroxycorticosterone, 50 nanograms/dl. Treatment: adrenalectomy -80% control HTN. Potassium, calcium channel blocker, potassium sparing diuretic, Cytarine, dexamethasone. Pheochromocytoma. Signs and symptoms, risk factors: a tumor of the center of the adrenal gland and medulla. Excessive catecholamines, epinephrine, norepinephrine. 10%, malignant. Severe hypertension. Risk factors: neurofibromatosis, multiple endocrine neoplasia syndrome. Age 40 to 60 years. Signs and symptoms: pain in chest/abdominal, hypertension, headaches, diaphoresis, palpitations, heat intolerance, tremors, apprehension. Diagnostic procedures, treatments. Laboratory test: vanillin-mandelic acid, VMA, testing, 24 hours. Urine collection: VMA normal level 2 to 7 mg/24 hours. Diagnostic procedures: clonidine suppression test, administration of phenethylamine, Regetin. Treatments: alpha-adrenergic blockers, prazosin, phenoxybenzone, beta blockers, metoprolol, lopressor, glucocorticoids, prednisone, deltason. Adrenalectomy surgery, complications of hypertensive crisis. NCLEX question number 1. A client is diagnosed with pheochromocytoma. A nurse prepares a plan of care for the client. While planning, the nurse understands that pheochromocytoma is a condition that 1. Causes profound hypotension. 2. Is manifested by severe hypoglycemia. 3. Is not curable and is treated symptomatically. 4. Causes the release of excessive amounts of catecholamines. Answer: 4. Rationale: pheochromocytoma is a catecholamine-producing tumor and causes secretion of excessive amounts of epinephrine and norepinephrine. Hypertension is the principal manifestation, and the client has episodes of high blood pressure accompanied by pounding headaches. The excessive release of catecholamine also results in excessive conversion of glycogen into glucose in the liver. NCLEX question number 2. A nurse is providing discharge instructions to a client who has Cushing's syndrome. Which client statement indicates that instructions related to the dietary management are understood? 1. I can eat food that have a lot of potassium in them. 2. I will need to limit the amount of protein in my diet. 3. I am fortunate that I can eat all the salty foods I enjoy. 4. I am fortunate that I do not need to follow any special diet. Answer: 1. Rationale: a diet low in carbohydrates and sodium but ample in protein and potassium is encouraged for a client with Cushing's syndrome. Such diet promotes weight loss, reduction of edema and hypertension, control of hyperkalemia, and rebuilding of wasted tissue. NCLEX question number 3. A nursing instructor asks a student to describe the pathophysiology that occurs in Cushing's disease. Which statement by the student indicates an accurate understanding of this disorder? 1. Cushing's disease results from an oversecretion of corticotropic hormones. 2. Cushing's disease results from an undersecretion of mineralocorticoid hormones. 3. Cushing's disease results from an undersecretion of mineralocorticoid hormones. 4. Cushing disease results from an increased pituitary secretion of adrenocorticotropic hormone. Answer: 4. Rationale: Cushing's disease is a metabolic disorder characterized by abnormally increased secretion, endogenous, of cortisol, caused by increased amounts of adrenocorticotropic hormone, ACTH, secreted by the pituitary gland. Addison's disease is hypersecretion of adrenal cortex hormones from the adrenal gland. NCLEX question number 4. A nurse is caring for a client with pheochromocytoma who is scheduled for adrenalectomy. In the preoperative period, the priority nursing action would be to monitor 1. Vital signs. 2. Intake and output. 3. Blood urea nitrogen results. 4. Urine for glucose and ketones. Answer: 4. Rationale: pheochromocytoma is a catecholamine-producing tumor and causes secretion of excessive amounts of epinephrine and norepinephrine. Hypertension is the principal manifestation, and the client has episodes of high blood pressure accompanied by pounding headaches. NCLEX question number 5. A nurse is performing an assessment on a client with pheochromocytoma. Which of the following assessment data would indicate a potential complication associated with this disorder? 1. A coagulation time of 5 minutes. 2. A urinary output of 50 ml per hour. 3. A blood urea nitrogen level of 20 mg/dl. 4. A heart rate that is 90 beats per minute and irregular. Answer: 4. Rationale: the complications associated with pheochromocytoma include hypertensive retinopathy, myocarditis, increased platelet aggregation, and stroke. Death can occur from shock, stroke, renal failure, dysrhythmias or dissection aortic aneurysm.